Okay, so we'll go ahead and get started. We've got several folks join us here in the room. There may be a few more joining, but I want to just get started and we'll wrap things up within the hour here. So thank you all for joining Cases with Castle Biosciences. Tonight we're lucky to have our invited speaker, Dr. Etan Marks. I'll be moderating the session. My name's Matt Goldberg. I'm the medical director here at Castle Biosciences, also joined by Carrie Damon, who'll be managing the chat and facilitating the conversation as the brand manager here for My Path Melanoma. Tonight, if you go to the next slide, Dr. Marks. I think
there we go.
Just a couple of housekeeping items. We will be monitoring the chat. You could raise your hand to have this be interactive, or we'll be available to answer questions offline as well, depending on time and whether or not we're able to address everyone's questions here tonight. The plan for these is to also post these online to be available for post viewing on the web, with cases posted for people's ability to review them offline. Next slide. And with that kind of out of the way, some of the housekeeping, I want to introduce Dr. Etan Marks, our invited speaker. Dr. Marks is a board-certified anatomic pathologist and clinical pathologist who also has 2 subspecialty board certifications in both hematopathology and dermatopathology. He completed medical school at Nova Southeastern University and completed pathology residency at Montefiore Medical Center, Albert Einstein College of Medicine, where he was also the chief resident. He subsequently finished a fellowship in hematopathology at NYU Langone Medical Center and a second fellowship in dermatopathology at UT Southwestern Medical Center under Dr. Clay Cockrell, where I also completed my DermPath fellowship. And this combination of fellowships really gives Dr. Marks a unique interest in cutaneous lymphomas, as well as cutaneous melanocytic neoplasia, and experience in multiple diagnostic modalities that include flow cytometry and multiple molecular assays, which are relevant for the conversation here today. Dr. Marks has also published over 30 articles in peer-reviewed journals and enjoys pursuing a variety of research topics and continues to be dedicated to teaching medical students and residents as well. So we're lucky to have Dr. Marks here with us tonight, and has published recently on My Path Melanoma. And so the purpose of these sessions is really to talk with clinicians who have incorporated diagnostic ancillary testing into their workflows of the diagnosis of cutaneous melanocytic neoplasia, and in particular focus gene expression profile testing with My Path Melanoma. Next slide, please. Here are relevant disclosures for the conversation tonight. Next slide. And I wanted to start just by giving a short introduction before passing microphone over to Dr. Marks, just about Castle Biosciences, our molecular program here, and really the focus of the conversation tonight, which is the My Path Melanoma test. So in the area of dermatology, Castle Biosciences has a range of molecular diagnostic and prognostic tests that are really guided to answer important questions that face clinicians for patients with impactful cutaneous malignancies. We have 2 prognostic tests in this space, the DecisionDx-Melanoma assay for patients with cutaneous melanoma to inform risk-aligned management decisions after the diagnosis of an invasive cutaneous melanoma, and DecisionDx-SCC for patients with invasive squamous cell carcinoma with 1 or more risk factors, again, to inform subsequent management for patients with these squamous cell carcinomas with 1 or more risk factors. In the diagnostic realm, we have a diagnostic ancillary test that will be the focus of the conversation today, the My Path Melanoma test, which is for melanocytic neoplasms where the distinction between a benign nevus or malignant melanoma can't be made with the tools that we use routinely in our dermatopathology practice. It can really aid in the disambiguation of these difficult-to-diagnose melanocytic neoplasms. Next slide. So just to lay the groundwork a little bit, I think it's important to talk about the range of diagnostic ancillary tests that are available to dermatopathologists in our practice. And these modalities look at different aspects of this kind of central dogma of DNA transcribed to RNA to translation to proteins. And when we think about diagnostic ancillary tests, I think it's important to think about where we're looking in this flow. And so in our clinics, we often use immunohistochemistry, which focus on proteins here on the far right, looking at both the presence or absence, location within the tissue, and relative intensity of staining of particularly relevant protein biomarkers in the tissues that we're looking at. On the far left, we have DNA-based assays that are looking at wholesale gains or losses in whole chromosomes or particular point mutations, assayed with either FISH or array CGH, SNP array, or next generation sequencing, but it's really looking at changes to the underlying DNA, mutational status. The focus of the conversation today is after transcription is taking place, looking at mRNA expression of genes of interest, specifically in the context of locked algorithms that evaluate or help to differentiate between benign melanocytic neoplasms and malignant melanocytic neoplasms, but really looking at the expression of particular genes of interest within a lesion that's difficult to diagnose using other modalities. Next slide, please. So again, gene expression profiling and GEP tests generally really measure gene expression, looking at particular genes of interest of the lesion in question in its macroenvironment. So you're looking not only at atypical cells, here atypical melanocytes, but also the surrounding tissue where these lesions are located. And you're looking at patterns of gene expression, comparing benign nevi to malignant melanoma, looking at the expression of the lesions that are submitted for testing to help identify whether the lesion is best characterized as suggestive of a malignant neoplasm or a benign neoplasm. Next slide, please. And these tests are developed using a well-documented discovery effort, looking at a broader range of target genes of interest that are then refined through training, where a specific set of genes are identified and then incorporated into a locked algorithm that is trained to differentiate between benign and malignant melanocytic neoplasms in the case of mypath melanoma. And then this is subsequently validated in a completely independent set of lesions to essentially test whether or not this locked algorithm can reliably differentiate between these two types of melanocytic lesions, the benign nevi and malignant melanoma. And this is the pathway that the mypath melanoma test has undergone through rigorous discovery and training of the locked algorithm and subsequent validation in multiple different types of cohorts, both retrospective cohorts as well as cohorts with known outcomes. Next slide. And just a little bit, just for the group of dermatopathologists, how the test is performed, I think, is important and relevant for this conversation. So the testing begins when a clinician identifies melanocytic neoplasm with uncertain malignant potential. That area can be identified or marked on the slide of interest. It's then reviewed by a dermatopathologist where the lesion of interest is abstracted or identified just to make sure that the lesion remains on the slide submitted for testing. The unstained slides that are submitted, 9 unstained slides in this case, are then macrodissected, identifying the area of interest, paraffins removed, RNA is extracted, RT-PCR is performed, and then we use qRT-PCR with a validated algorithm that's described in that training and discovery to then return a result of a benign gene expression profile suggestive of a benign neoplasm, gene expression profile suggestive of a malignant neoplasm, or an intermediate result. And that result is returned to the clinician to inform the diagnosis of the melanocytic lesion that's submitted for testing. Next slide, please. And here, this is a schematic of the mypath melanoma assay that includes 23 genes, discriminant genes, as well as reference genes that are then routed through a classification algorithm to return the 3 results that I just described, the malignant, intermediate, or benign gene expression profile that is then incorporated into the information that is already known about the lesion. Dr. Marks will emphasize this, but it's interpreted in the context of the histopathology, the clinical factors, as well as other laboratory information that's known about the case to inform the best diagnosis with the most confidence and clarity for our dermatology colleagues to inform relevant management decisions and subsequent surveillance. Next slide, please. And the evidence supporting the mypath melanoma test has started here with the initial development and validation in 2015. That includes analytic validity, clinical validity, and clinical utility for dermatopathologists as well as dermatologists, and spans the research that's seen here. Any additional questions that will follow here, we'll be happy to follow up offline and provide higher level detail about any of these manuscripts at any point. Next slide, please. And finally, we believe that the strength of evidence that supports the mypath melanoma test and has informed the perspective of both appropriate use criteria committees as well as multiple guideline associations that discuss a range of diagnostic ancillary tests, modalities that can be used to help inform the decision and differentiation between benign nevi and malignant melanoma. And gene expression profiling is included as one of the diagnostic ancillary tests that may inform this distinction when such a distinction cannot be made using the tools that dermatopathologists have in their clinics. And I really think that the strength of evidence that has incorporated these in particularly relevant scenarios as part of the tools that can be incorporated in the DermPaths tool belt. So with that, I'll pass over to Dr. Marks, and thank you again for your attention, everyone, and look forward to discussing the cases we hear tonight.
Thank you, Matt. So I also just wanted to give a quick introduction of why I like MyPath, and just a couple other salient points. So as Matt so beautifully described, MyPath is a gene expression profile test. And the reason I personally like it in theory more than something like FISH or ACGH in and of itself, FISH, when we know that when it's worked up, you have a non-pathologist looking at cells and finding something. So unfortunately, working in the FISH lab, I saw many issues with that, where they looked at the wrong area of interest. Whereas here, what Castle has done is they use a pathologist to find the area of interest, and that's what they macro dissect. That's what Dr. Goldberg was talking about. So you actually know that you're getting the lesional cells that you want because you have a pathologist actually choosing it. And ACGH is something that requires so many cells that many times you won't actually get an answer, because the melanocytic lesions that we deal with on biopsies frequently do not have enough DNA material. That's just some technical points why I like the idea of gene expression profile in general. And the other thing is, all of us know, especially more recently with all of the biologics and the immunotherapies that exist, we know that cancers are very dependent on the immune system interaction with them. And one of the things that MyPath does is not just use genes that relate to carcinogenic, but also the immune system. So those are just a couple of points why I like the idea of MyPath and why I think gene expression profile in general works better than some of these other ancillary tools that frequently do not give an answer, or as opposed to, I think MyPath frequently will give an answer. That being said, as I tell everyone who will listen to me, MyPath has to be ordered when appropriate. And that being said, if you have an answer with a SOX10, you don't have to order a PRAME. If you have an order with SOX10 and a PRAME, you don't have to order molecular. So if you have histology where you don't need to order anything, you don't order any SOX10 or PRAME, because that'll just confuse the matter. So this is exactly like that it should only be ordered when appropriate, when there's an ambiguous lesion, after you've done your full workup that you can do in your own lab. And that is very important, because if you send every single one of benign lesions, if it's inappropriate, you shouldn't use MyPath as a screening tool, something that helps differentiate. And you can use your clinical judgment based on that, whether MyPath will be useful to you in those situations. So that being said, now I'm going to introduce the 5 cases that I had a different reason in each one of the cases to send it. And the last thing that I'll say is, you only want to send this test when you know what you're going to do with a positive result, you know what you're going to do with a negative result, and you know what you're going to do with an intermediate result. If you think you're going to get those results back, and then all of a sudden you're going to be like, now I don't know what to do, that is not the appropriate time to send the test. Before sending it, you should think about, how am I going to use these results? Okay. So our first case is a 34-year-old male who had a family history of melanoma in his aunt. And he had this lesion on the face that had 2 different areas that looked a little different to the clinician. So they sent in 2 biopsies. So here you can see it's a polypoid lesion, and it's not the best picture, but you can see part A was more of the superior aspect and part B was more of the inferior aspect. Part A might have had a little bit more inflammation, red. That was clinically, it was a little bit heterogeneous as a clinical lesion. So luckily we have the whole slide images, so we can go through it nicely. So on low power view, we see this intradermal melanocytic proliferation that, as some people in the past have described this as the puffy shirt sign. I think there was an article with Seinfeld where already it's a little bit worrisome because it's expanding the papillary dermis, and the cells, even on low power, look large and maybe a little pleomorphic. So unfortunately, it had a mitotic figure here, which really piqued my interest and made me extra worried about possibly being melanoma in a 34-year-old. So going back to low power, you can see that these cells, some of them are large, they're pleomorphic, some have pseudo-inclusions, a lot of them have prominent nucleoli, and although it does show some maturation and maybe even give off a little bit of a congenital feel because it wraps around some adnexa, I was very worried about this lesion. Unfortunately, I don't have all the IHCs because it was sent to an outside institution, but I will show you a couple of the IHCs. So this was the HMB45, which some people like to use. I usually don't use, but it is usually pretty good for delineating maturation. And here it showed some strong staining in the upper half, but even in the lower half around some adnexa, there was still some strong staining. So this had me a little bit worried, but HMB45, I think, is not very reliable to differentiate any type of malignancy. Here's the stain that everyone loves nowadays, PRAME. So PRAME, as we know, is described as really only useful to tell you that something is highly worrisome for melanoma when it's diffusely 4+ positive, according to the literature. But what I have found is that when PRAME is diffusely positive in a lesion like this, even if it's 1+ or 2+, like in this situation, and the way you can tell is you compare it to the squamous nuclei, and you have to make sure that, excuse me, that your squamous nuclei sometimes can be overstained, so you need to make sure that you have a control. But here we can see there's some 1+, maybe even slightly 2+ staining throughout the entire lesion here, and it gets a little bit weaker by the bottom, but pretty much throughout. Now, unfortunately, my other PRAME stain, which was even better than this one to pique the interest, it is at the outside institution, so I can't show that. But the second biopsy that was done on the same lesion was even more worrisome, and this one had even more pleomorphism, more dusky cytoplasm, and also had mitotic figures. Not many, but a couple. So it was a highly worrisome lesion, but because there was nothing perfect about this, see, here's another mitotic figure, another. So this is highly worrisome for a melanoma, but the staining pattern, as you can see with other things I did, the other stains, especially the PRAME, were not definitive. So I was highly worried about the lesion. Now, being on the face, I wanted to make sure that this was a melanoma before suggesting a large excision. It's a very deep melanoma. This is a PT3A because it goes, I think it was like 2.5 millimeters. So I wanted to make sure that I was definitive that this was melanoma before definitively calling it in this situation. And here again, HMB45, similar staining. So this is just a description of the histology that I put into my report. There were some spitzoid features, as we saw. There were large, dusky. There was a large pleomorphic cells, some dusky cytoplasm, it was highly worrisome, but there have been a lot of described spitzoid lesions that can have this morphology. And especially in this age group, 34, that's where a lot of people say it's probably melanoma if it's spitzoid. Could it not be melanoma? Could it just be an unusual spitz? So I ended up sending it for MyPath. And here's the description of the IHCs, but I'll skip over it since I described it. So once I sent it for MyPath, I sent both of them in order to make sure that they were concordant, to make sure the entire lesion was melanoma and not a melanoma rising in a background of some type of intradermal nevus. And both of them came back very positive, 2.1 and 6.4, which if you can see the scale, it goes from negative 16.7 all the way to plus 11. So the actual numbers are essentially meaningless. It has to do with the amount of RNA being expressed, but the validation showed that if it's in anything above 0 positive is essentially melanoma, and anything below negative 2.1 is not melanoma. And anything between negative 2 and 0 is indeterminate. It could be melanoma, could not be melanoma. And that's an important point. But because I got back a positive result like this in both lesions, I was able to give the patient the appropriate diagnosis, even though he's 34, it was on the face. And his closest relative that had a history of melanoma was his aunt. So I thought that this was an appropriate situation because it gave me the extra confidence to definitively call this a melanoma. And now the patient has gone for systemic workup, as he got a brain MRI. I'm not sure if he got a lymph node because I haven't had the follow-up information for that, but the patient is appropriately being treated, and it's also been confirmed at outside institutions. They agree that it's a melanoma and everything. So in a community pathology practice or dermatology practice, I was able to make sure this patient got the appropriate care. So case number 2 was a 30-year-old patient that I've had several biopsies from, and he has a history of melanoma as well as squamous cell and basal cell. He has the genetic mutation for xeroderma pigmentosa. So clinically, this was very worrisome. Unfortunately, it's a blurry photo, but you can see it's a large pigmented lesion, and they took a biopsy of it. So low power view, you can see it's mostly intradermal on all pieces. And honestly, if this wasn't xeroderma pigmentosa, on low power, you would think, oh, this is simply just an intradermal nevus. But hold on. There we go. So on higher power over here, you can see that there looks like there's 2 populations, a larger population and then a maturing population at the base. Although it does look similar to those cells that we saw in the previous case, where you have these larger pleomorphic cells, irregular pigmentation, maybe some spitzoid features. Then you can see basically 2 populations, the larger cells, the smaller cells. But these larger cells, very pleomorphic, atypical, the irregular pigmentation is worrisome. There's even some inflammation here. So going through this biopsy seems like a highly worrisome lesion. And over here was the area that really worried me, where there was abundant inflammation. I thought maybe there would be some epidermal component, but these pleomorphic spitzoid cells over here had me wanting to work up this case more. So here, this is the description of a population of larger, more epithelioid with abundant dusky cytoplasm, some prominent nucleoli, irregular pigmentation, something that makes you want to at least get IHCs. So then when I got IHCs, SOX10 highlighted that this was purely intradermal. So it basically, this is representative of all of them. And then the PRAME stain is what really got me worried, as we know, because the PRAME was diffusely positive, 4+ in these larger melanocytes. But the smaller melanocytes, although they were positive mostly, they had patchy and a little bit weaker, maybe 2 to 3+ staining. So this, to me, was highly worrisome for some type of highly aggressive or aggressive melanocytic lesion that was arising from a pre-existing nevus. And the HMB45 was similar in the sense that it showed positivity in that larger population and negative in the smaller population. And the other thing that worried me was the Ki67 showed these larger cells had a higher proliferation index, whereas I would say it's probably between 5 to 7%, something like that, which is worrisome in a melanocytic lesion because you really want basically 0 to 1%. And because I thought, well, maybe this is just a DPN or DPM, as people like to call it now, I got a beta-catenin, but that as well was negative. As we can see, it was only positive. It was not positive in the nuclei, which basically means that it's not a positive staining pattern. So because of all of these features, I wanted to send it for MyPath. And the way I usually sign these out, as I should have said before, is I let the clinician know that I'm worried about it by saying, you know, compound melanocytic proliferation or intradermal melanocytic proliferation with unusual features, and tell them I'm working it up for with molecular testing, and that it usually takes between 1 to 2 weeks, depending on the male, depending on different situations, but they should be able to expect an answer within 2 weeks. And in this situation, I also wanted to send it because of the patient's history of melanoma and genetic mutation of xeroderma pigmentosa, which made it more likely that this was going to be a melanoma. As we know, they're more susceptible to those. And the molecular testing came back and it was positive, which confirmed my suspicion, especially because of that PRAME and HMB staining and so on. So what would I have done if it came back positive? I would have just called it an unusual nevus. I still most likely would have called it, said that it needs to be re-excised, but it would not have been a melanoma. And that would have really changed the follow-up care for the patient, because I think this was his first melanoma in the past 5 years. So it changed the management for the patient, which is what's important.
If it had come back a benign GEP, I think
if it would have come back benign, it would have completely changed the management, because it would have just been maybe a very narrow excision at like a compound dysplastic with severe atypia instead of an actual melanoma. This one, they had to be worried, make sure they go a wide local excision, and then follow-up care for the next few months to make sure that the lesion doesn't come back, that they got it all, and so on. You know better than me because you're a clinical derm.
But even comparing case 1 and case 2, one is a higher stakes case, a T3A, right, versus this a T1A in your final sign out. But still, with kind of you're describing some of the relevant, what's at stake for the patient is still significant between the different clinical moves for both of these patients, it sounds like.
Right. Especially because once a patient has multiple melanomas diagnosed, that often people don't think of this, but it changes people's perception of them, from their doctors to the insurance companies and so on. So there is a lot of, I don't want to say stigma, but there are a lot of external factors that occur when you have multiple melanomas, even if the patient has a previously diagnosed melanoma. People often think that, oh, they have one melanoma, a second melanoma diagnosis isn't it the biggest deal. It is still something that has a lot of gravity in their life. Also, emotionally, it's very difficult to deal with, and so on. So that's always something to think about. Why should I do this additional test? Why should I give a definitive diagnosis? Why is it important to consider those things, essentially? So this ended up being, I only measured it down to the PRAME diffusely positive cells. So, and I called it a melanoma arising in conjunction with a background nevus, because that's what I believe was happening here because of the protein pattern. So I was using in conjunction the molecular test along with the IHCs to help me come to the best diagnosis. Okay. So case 3.
Dr. Marks, I think we may have a question, actually. It looks like Dr. Yang may have a question. I saw a hand raised here. It can be typed into the chat, or if we want to unmute here.
Do I have the ability to unmute?
I think we do. Dr. Yang.
Yes, thank you. I got a question about this case. Very interesting. Initially, did you you go back to the HE? You see two population cells, right? In the dermis.
Yes.
So basically, when you have a larger cell, they don't have the DPM looking. But I was thinking, if it's two population cells of the larger group, normally, did you do a BAP1? I was curious, if this one is a BAP1 inactive with melanocytoma, what will show up in the MyPath? Are they going to call, is atypical, or is fall in the category, or, really curious to know if it's BAP1 inactive or not. I know this is kind of tricky, just by morphology itself. I know it's pure dermal base. You have two populations, biophenotypic. I have a larger cells there, and the cell normally, you will elicit a little bit inflammatory cell, response.
So I can tell you that I did not do the BAP1 stain,
Okay.
but this patient was followed up, and we did the melanoma profile NGS for prognosis, because they wanted to know like BRAF and all that stuff, and it was negative for BAP1.
Oh, negative. Okay, that's interesting to know.
So
yeah.
I know that it was negative for the BAP1, but yes, I definitely, I hear what you're saying. That is one of the things about MyPath is it had, when it was validated on, I think it's a total of what, 2,300 cases that it's been validated on now, Matt?
I'd have to go back to give you the exact number of cases in validation. I don't have that off the top, but
yeah.
I believe there were some Spitzoid ones that had a couple of HRAS definitive and BAP1, and I believe it put them in the correct category of benign.
Oh, wonderful. So for this case, besides BAP1, you didn't do it, but could you figure it out initially, like doing I didn't see your print, P16. How does the P16 look?
I did not do a P16 because
okay, gotcha.
I don't like P16s, and you'll see I have a P16 on a couple other lesions.
But P16 only is a loss. I know. I have the same feeling, unless it shows loss, complete
but
loss.
Even when I have loss with P16, half the time they're benign components, and
no, you have two population here. One population loss means something, definitely.
Right. But I already had the frame, so I didn't think it was necessary with the P16 personally.
Gotcha.
And Dr. Yang, one of the things, and I tried to emphasize this in the introduction, is that the histologic interpretation that you provide prior to ordering the test remains relevant after you get the MyPath test result. And so it's important to interpret the results, as Dr. Marks kind of highlighting, in the context of what you know about the lesion. It's an important kind of integration. I think Dr. Marks you're explaining it really, really well here.
Well, and it's not just that. Also, there's been a lot of articles that came out about if BAP1 is lost, how do you know it's still not melanoma? Because there have been many BAP1 loss happens in melanoma. So even if you had BAP1 loss, how do you know it's not still a melanoma? Which is why most people, or they came up with the new category of BAP1
melanocytoma,
because they're just not sure yet. So that's going to be something interesting to follow. But even even with BAP1 loss, which we know is a genetic marker, if it's a germline mutation, if you have BAP1 loss, you're in a much higher risk for melanomas. So it's an interesting thing to follow along. But I personally, I didn't think this was a BAP1 mutated nevus, because the ones that I've seen usually have a distinct cluster of populations. Distinct cluster of the BAP1 mutated population, and all the other pieces usually have the regular background nevus. That's mostly how I've seen my BAP1 mutated. Over here, you can see that there's kind of a mixture of these cells throughout, if that makes sense. So to my eye, a BAP1 mutated nevus wasn't really high on the list because of that, but I definitely see why one would think that that's a possibility. Okay. All right,
All right,
Dr. Saeed,
we have one more
question?
question here, and then we'll keep moving to the additional 3 cases. Dr. Saeed?
Yes, hi. I didn't know if I could ask in the middle. I was actually holding my questions to the end, but if it's interactive from the during the talk, I just have 2 questions. Dr. Marks, both of these cases don't have a junctional component, right? So,
Well, this one had a junctional on my initial slide, but it doesn't have
okay.
agitoid spreading. But this had, I don't know if on this slide it has it. There was
Okay.
a small junctional components on one of them. I think it was on the initial slides that I had.
Okay, so my question was that if you have a predominantly intradermal proliferation, is that a good setting to use MyPath? Because I would have thought that because of the possibility that it could be a MET, or it could be a nodular melanoma lacking a junctional component in the biopsy that you got. Does that affect your decision on whether to order MyPath or not? The presence
way I'll
or
answer that-
absence of a junctional.
So the presence or absence of a junctional component in and of itself would not. The main thing, the reason why MyPath, they say that MyPath shouldn't be ordered on metastatic lesions is because it has not been validated on metastatic lesions. So they can't give you definitive evidence that backs up for metastatic lesions. But for intradermal melanocytic proliferations that you are confident are primary, you can definitely order it. If you have a question, then it's like IHC or any other molecular test, and I would say it is a tool you can use to help you come to a conclusion, but it is not, it's not validated for that. And
Sure.
And then just to add, Dr. Saeed, you know, the MyPath melanoma test won't tell you whether it's primary or metastatic. It does
Of
not
course.
help with that distinction, and it's only valid, as Dr. Mark said, for primary cutaneous melanocytic neoplasms. And so
Right.
we have
right.
SOPs in the laboratory that if they're that we do not accept lesions where they are metastatic, and we are looking for primary cutaneous melanocytic neoplasms for testing. So that's a requirement for testing, that it is primary.
But it doesn't matter if it's predominantly intradermal, because I was under the impression that if it's predominantly intradermal, then might as well not send it, because there's always a possibility that it could be a MET. But
it's a clinical judgment at the end of the day, and if there's particular uncertainty, then disclaimers can be had. That often will result in a peer-to-peer. The test is not validated for metastatic lesions, and so if there's significant uncertainty, then it can be the case that testing is foregone, because again, it is not validated for metastatic lesions. So it requires the clinical confidence that it is a primary cutaneous melanocytic lesion, either by history or by histopathology, but there needs to be confidence that it's primary to allow testing.
Right.
It's not a decision that Castle makes, it's from the ordering clinician.
What I will say on that is this as well, is that if you're unsure whether it is primary or metastatic, if it's metastatic, it's definitively malignant.
that's correct.
And if it is primary, then MyPath is useful. So,
Yes.
so that's how I kind of look at it in that sense, if you're really in doubt. But many intradermal melanocytic proliferations, you can often tell if like 9 to a 90th percentile degree of certainty whether you think it is whether it is primary.
Right,
I
right.
would say.
Thank you all for the questions, and we'll move forward with case number 3 here, Dr. Marks.
Yeah. Let's go. Okay, case number 3. So this was a 54-year-old man, no previous history of skin cancer, no history of melanoma, no family history, but he had a suspicious pigmented lesion on the periumbilical skin. This was a fun case to do. So periumbilical skin, it was nice and annular, but it had very odd pigmentation. So it was worrisome, and they took a biopsy. And that biopsy showed a lot of inflammation, but otherwise it seemed like a pretty symmetrical lesion. But if you go on higher power, if you go on higher power, you can see it's very spitzoid appearing inflammation, but spitz nevi can have abundant inflammation, right? You have the fascicular melanocytes, you have the pagetoid spread, you even had some possible caminobodies, but and there's even the discohesion. So I really thought that this was probably a spitz nevis, but since he's 54, spitz nevis, very uncommon, irregular pigmentation. These things all worried me. You know, throughout the lesion, you had this inflammatory infiltrate, and it was just highly worrisome. But as my friend Henry knows, there's a lot of different spitz lesions that can have a lot of different types of mutations. So, have any more? Yeah. And the third piece, it was the same thing. So if you see, it was mostly all taken out. It was pretty symmetrical, even though there was abundant inflammation, but it was, you know, focally positive at the margin. So very, very spitzoid, a lot of inflammation, but there's areas of dermal infiltration that we were worried about. So SOX10, I always get a SOX10 with the PRAME as well. I'm never going to get a PRAME without a SOX10. I want to be able to see definitive melanocytes because PRAME sometimes stains randomly. But you see the spitzoid cells all positive, some pagetoid spread in the middle of the lesion, and so on. So I really thought this was probably a spitz, but like I said, 54-year-old, very worrisome. PRAME was dead negative.
Were there internal positive controls here with the PRAME, or hard to find?
I believe the one positive control that they don't tell you about are sebocytes. So if you use the one PRAME stain that is pre-diluted and ready for use, I forgot which company it is again. I forgot the name of the company, but the sebocytes will all be positive. So that's a nice internal control for PRAME. If you don't have sebocytes on your biopsy, you're out of luck. Then there's no internal control. But that's the nice thing about this PRAME. And then I got a P16 for my friend Henry. And this is the type of P16 staining pattern that I get. Some positive cells, some negative cells. But like he was saying, you know, if there's one population and it's heterogeneous, it doesn't necessarily mean much. If you see two different morphological populations and you see P16 staining one and it's negative in the other, that actually could mean something. But here you see in the invasive in the dermal part, it's all positive, you know, and it's very important. This one also has to be nuclear as well as cytoplasmic for the P16 staining to mean anything. So I had a heterogeneous P16. And then the HMB45, diffusely positive, and even in the dermal component. So I was worried about it. So I sent it for, can't remember what I sent first, the NGS panel or the MyPath, but MyPath was intermediate, which means that there's some type of genetic mutation that the test is picking up, but not sure if it is of clinical relevance to call it melanoma. And the other thing I did is I did an NGS panel, which found out that P10 was deleted, which I have found to be extremely unhelpful because you have a host of lesions that are P10 negative that mean nothing. But pan-Trek were all, the NTRECs were all negative. BRAF was not mutated, HRAS was not mutated, KRAS, NRAS, all the genes in these large NGS panels. Unfortunately, I had not started doing the thyroid fusion panel to see if it was one of the fusion kinase genes. But based on this, even if there was a fusion kinase, I still would have called it an atypical spitzoid tumor because of the abundant inflammation, the atypia, the MyPath test, and the age of the patient. I wanted to treat it more aggressively than, and also a 54-year-old, if you're calling something a Spitz nevus, you have to be very confident for that, because Lebois' book says they're over 50 and you're calling it a Spitz nevus, you better be sure. So that's why I ended up calling atypical spitzoid tumor. And I found the MyPath very useful because if the MyPath was negative, maybe that would have given me the confidence. But because it was intermediate, I wasn't going to call it melanoma because I really don't think it's melanoma. But I'm still also not going to say, oh, it's just a Spitz nevus. And I also did NGS, which backed up the unusual features of this lesion.
Right, and you're also, each of these cases has slightly different workups that you're describing, right? So kind of
Right.
You're tailoring the type of ancillary test to the questions that you have, and I think that's kind of a nice ecology of, or diversity of different options that are presented here in the 3 cases so far.
Okay, so case 4, 37-year-old female with no significant history of any type of cancer. She has a family history of melanoma in a cousin, and she had a suspicious lesion in her left distal posterior upper arm. So here, unfortunately, it's a blurry picture, as are most of mine, but at least I have clinical pictures. It was very dark and irregular. And on histology, this one had a lot of inflammation, but it was only a partial biopsy, and it had a lot of spitzoid features as well, where it had some discohesion, and it had some of these pleomorphic melanocytes, a lot of dusky cytoplasm, pleomorphism, irregular pigmentation. I think I even saw a possible Camino body. No, but there's pagetoid spread as well. So I was thinking this is either a partial biopsy of a Spitz nevus because she's 37, or this is melanoma. That was going through my head. We have irregular inflammation. We have a lot of pagetoid spread, but we have these larger spitzoid-like cells. So I didn't even, and I can see the pagetoid spread. I can see the atypia. I know that Spitz nevi can be positive for PRAME. Would PRAME positivity have me call this a melanoma in a 37-year-old? I wasn't feeling that confident about it. It wasn't that large. So I decided to go straight to MyPath for this one because I wanted to just know, is it malignant? Is it not? And it was malignant. It backed me up, and I was able to call it with confidence. 37-year-old diagnosis, like the 34-year-old, was not something I wanted to mess with. I wanted to be able to have significant confidence to be able to, give this young lady a diagnosis of melanoma, and I felt that this was the appropriate approach. And SOX10, PRAME, P16, none of that would have helped me in this situation. Be confident enough. So, I mean, it was a thin tumor as well, but still, this was going to be her first diagnosis of melanoma. So in case number 5, 41-year-old female who's being seen for evaluation of a skin lesion, no history of melanoma, suspicious lesion. Again, sorry that it is blurry, but irregular pigmentation is basically the theme. And on higher power, very similar to the last one, where we have this irregular inflammation, spitzoid morphology. This one actually had a Camino body, but she's 41, and there's some sclerosis, there's some fibrosis, very large atypical cells, which could mean they're spitzoid, could mean they're BAP1, you know, so it could, which some people consider BAP1 nevi or melanocytoma as a variant of the Spitz. So this one, I wanted to make sure that 41, still pretty young. High power, you can see these large atypical cells. You know, the spitzoid morphology is basically the theme of these. And I got a SOX10 and a PRAME on this. So the SOX10, diffusely positive, highlighted some hydrotoid spreading melanocytes. Sorry. Right, hydrotoid spreading, mostly over the middle, but irregular inflammation, large atypical cells, lots of fibrosis, highly worrisome. And then the PRAME stain, like in that other gentleman, diffusely negative, but is that enough for me to be like, oh, okay, well, I guess it's nothing. And also the other thing you can see is there was some weak positivity, which it's not showing up great here, but there was some weak positivity in this stain. So what does that mean? In the first case, it meant, you know, if it was diffusely positive, it means it's melanoma. It's only focally positive. All right, what does it mean? So in order to be able to call this a Spitz because of the fibrosis, irregular inflammation, partial biopsy, I got my path, and to my relief, it was in the negative range. I was able to confidently call this a Spitz. And because I followed the Empath DX guidelines, I still suggest that Spitz should be completely removed. But as I learned from Dr. Cockrell, the difference you say is conservative excision is acceptable, narrow margins should be fine. And those are my 5 cases.
In that last PRAME stain, I mean, we were looking quickly, but also I think that the issue around no negative control, no internal positive control in a biopsy specimen like that, I think is also a limitation in that sample where you have a negative PRAME, but it can be difficult, as you mentioned, to interpret in the setting without
Well, that one didn't have an internal control either.
Right.
Because there was no, hold on, sorry. If I show you this, there was no sebocytes here, right? You can see there's no sebaceous glands. So no internal control.
And I think you mentioned this at the outset, you know, if you have these are cases where you've used MyPath, and you know, if your question is answered using the workup that you have, as you articulated at the beginning, you don't have a relevant question, and additional ancillary diagnostic testing wouldn't be medically indicated or necessary or valuable for the patient. But I think I've really enjoyed the conversation, kind of your discussion of talking through the cases about this is a test that is available and can be ordered by clinicians who are struggling to differentiate between these different cases. And you've shown higher stakes cases and lower stakes cases that hopefully resonate with those attending, kind of that you've seen lesions like this in your practice, and identify when you can use this test conscientiously and in a manner that benefits your diagnostic workflow. So I really appreciate you taking the time to think through these cases, share them with everyone here tonight. And in the remaining time, I'll open it up to additional questions. to Dr. Marks here from the audience, and I want to thank everyone for their attention and participation in the session tonight. I see Dr. Said has another question here. If we can unmute Dr. Said.
Yeah, sorry. This is possibly a silly question, but I've noticed that on your MyPath requisition, there is a question, does the lesion have spitzoid features? What is the reason for that specific question? Does it change the kind of testing you do, or what's the relevance of that?
Yeah, so that in the current requisition form, that's actually a question that is, I believe, no longer part of the requisition form. Carrie, can we confirm that in the current requisition for the updated form?
That is correct. It is no longer on the current form.
And so, Dr. Said, it was related to a different diagnostic ancillary test that is not currently clinically available, where there was slight differences in the algorithmic output for lesions with a spitzoid morphology. This is in contrast to the MyPath melanoma test, where that is not relevant for the function of the algorithm. So that's why on the current form, where MyPath is the diagnostic ancillary test provided by Castle Biosciences, that the spitzoid morphology is not part of the requisition. So if you want, reach out, we can provide updated requisition forms, and you'll find that that is no longer designated.
Oh, okay, thank you.
All right. Well, thanks everybody for joining us. I had fun. I hope you did too.
Yep, and again, we'll take any feedback about this. This is really the beginning of the conversation where we're trying to bring cases to dermatopathologists from other colleagues who've incorporated diagnostic ancillary testing and specific gene expression profiling into their workflow in the efforts of explaining scenarios where these tests can add value for diagnosis and for colleagues in dermatology with confident, definitive reports. I'll make one plug here for a manuscript that's recently come out online. Dr. Marks is a co-author here on a manuscript about how diagnostic GEP can be incorporated into practice. Dr. Marks, I believe it's online. I think you sent it out on your
Yes.
social, correct?
That is correct. It's in the JCAD.
And so
It's on their front page, their April issue.
And so that's another place to kind of get more information about how these tests can be used. And we'll continue to alert everyone here about additional conversations with other dermatopathologists that we'll have. And really, we'd be open to feedback about if you enjoyed this type of session, this type of format, if you'd like to see more cases, and really appreciate everyone's participation and attendance and attention here tonight. So thanks, Dr. Marks, and really hope everyone has a great rest of their evening.
Thank you, everyone.